All right, let's dive in. I need this out of my way. So I'm going to start out with statistics. Um, Now, some of these statistics might be a little bit old, but about 46,000 Americans die by suicide, making it the 12th leading cause of death. Um, I'm going to turn my ringer off. It is the third leading cause of death for ages 10 to 19, second leading cause of death from 20 to 34, fourth leading cause of death for 35 to 44. Over a third of people who died by suicide were 55 or older. 10% of Americans have thought about suicide, and 1.2 million Americans have attempted suicide. Um, and 54% of Americans have been affected by suicide in some way. So this is something that's very, very prevalent in the United States. 90% of those who have died by suicide had a diagnosable mental health condition at the time of their death. 46% of Americans age 18 and over living with a mental health condition received treatment over the past year. And 72% of communities in the US did not have enough mental health providers to serve residents in 2021. Men die by suicide almost 4 times more often, while women were almost 2 more times likely to attempt. 54% of firearm deaths are suicide. 53% of suicide are by firearms. In 2019, the suicide rate was 1.5 times higher for veterans than non-veteran adults over the age of 18. The age-adjusted suicide in 2020 was 13.48 per 100,000 individuals. The rate of suicide is highest with middle-aged white men, and on average, there are about 130 suicides per day. Um, so this is nationally. Um, Interestingly enough, and I didn't get these slides uploaded, but it's worse. It's a higher rate in Utah. It's a much higher rate for men, but it's also a higher rate for women. So these statistics, it may sound alarming, but here in Utah, it's even more prevalent. So white males accounted for almost 70% of suicide deaths in 2020. 93% of adults surveyed in the US think suicide can be prevented. Okay, so it's prevalent. We know that it's a problem. We know that there's perhaps cultural aspects of men not feeling like they can talk about their problems, just feeling like they have to push through. So it's something that we need to be aware of, but also not just on a global scale. Most of what I want to talk about today is what to do as a therapist. So this is setting the stage, but what to do if you're having a therapy session, a client walks in and they say, I want to die. Got a gun in the back of my car, or something equivalent. So the first thing that we would want to do is be able to assess risk. We want to know, is this likely going to happen? Is this a low risk? Is this medium risk? Is this high risk? And what do we do? What do we do if it's low risk? What do we do if it's high risk? What's the next steps after that? So there's a lot of different types of scales. So there's Beck's scale for suicide ideation. There's Columbia Suicide Severity Rating Scale. There's Child Suicide Risk Assessment, Adult Suicidal Ideation Questionnaire, the SysMap Suicide Risk Assessment Scale, and Pierce Suicidal Intent Scale, and there's others. Um, so there's disadvantages and advantages to each of these. So something like a hospital setting, Columbia Suicide Severity Rating Scale. This in a behavioral hospital setting is perfect. This has a lot of research behind it. Someone comes in, they're wanting to know if they're safe. We're wanting to see if they should stay at the hospital. So this is perfect. Um, but sometimes patients will say at the end of therapy, there's 5 minutes left of therapy, and they say, I didn't want to tell you this, but I'm having suicidal thoughts. So something like this, the Columbia Suicide Severity Rating Scale might not be doable in that scenario. Um, so I'm going to go over kind of like the pros and cons and what to do with those scenarios. Um, like I said, there's a lot that are lengthy and have a lot of studies behind them, which is good. And some of them are quick and to the point, but they may lack scientific support. So they may not be as accurate. So there's some proposed DSM-5 suicide dimensions. Um, and it has a score of like lowest concerns, some concern, increased concern, and high concern. So likely with a high concern, if you get five out of these, um, that would be considered high risk. At that point, the next step would be to have someone go to the hospital. And we'll talk about the different ways to do that and how to do that. But let's go through these risk factors. So if there's a past suicide attempt, that's a risk factor. Long-standing tendency to lose temper, become aggressive with little provocation. That is a risk factor. Um, a big part of suicide is the impulsivity. It's not just the depression, but it can be the impulsivity with it. If someone's living alone in chronic severe pain, or recent significant loss, like within 3 months, that's a risk factor. Um, if someone has a recent psychiatric admission, if there's or a new diagnosis of major depressive disorder, bipolar, schizophrenia, that's a risk factor. Um, if someone starts abusing alcohol or worsening depressive symptoms, yes. If someone has a plan, yeah, that's very telling. Um, if someone has feelings of hopelessness, to me, this is my perspective here. But when someone does not see light at the end of the tunnel, I get worried. So to me, I put weight to that. Um, so all of these are things you could take this and you could say, okay, this can be done in 5 minutes. I can go over this with my patient. You can have this saved on your hard drive or on your computer or a link to it. And okay, let's go through this. Let's see how concerned we need to be about this. And maybe you go through it and it's lowest concern. Okay, you can set up a time, schedule an appointment to talk about it further, recommend that they set up a doctor's appointment for medication. You know that there's no immediate risk. So this is one faster way that you can go about it. Crisis lines have a fast risk assessment. Many years ago, there was a teen line that was a crisis line where teenagers could talk to teenagers. And this is actually how I got introduced to this type of work. At 14, I volunteered. And at 14, I was talking to my peers about their emotions. So we were taught to reflectively listen, and we were taught this is how you determine risk. If there's thoughts, plans, means, intent, and behavior. They had to simplify it for us so that as kids, we could notify the therapist there. They could get on the phone. If it's high risk, they could call and get someone to the individual. Um, but if there's just one of these, if someone just has thoughts, we would think, okay, this is low risk. They don't have plans. They don't have means. They don't have intent. They don't have past behaviors. These are just thoughts that are coming and bothering them. That's a risk, but it would, in this situation, we would consider it a low risk. If they have thoughts and maybe plans, but they really don't want to go through with it. They don't have that intent. They've said in their mind, okay, if I were to do it, I would do it this way. But I really don't want it. The person hasn't done it in the past. Okay, yeah, that's a risk. That's not low risk. That's medium risk. So that might, in that situation, even then, we might not have the police come, but we would kind of see if we could de-escalate them and get them proper treatment, and refer to therapist. But when we had three of those, so we're on the phone, we have thoughts, plans, they have the means. Okay, that's high risk. We need to do something right now. Um, so we didn't wait till there was four or five. We would go with that. So this was the what Teen Line used here in Utah. I don't think it's around anymore. Um, so that's what that crisis line assessment would use. And it's very similar to triage points of the Columbia, the Suicide Columbia rating scale. I can't say the full thing, but the acronym. So there's a small difference where there's desire instead of thoughts. Or no, see, desire, thoughts, plans, means, and desire, thoughts, and plans. So with the triage points, it wouldn't include means. But this is something that I like because it can be done like that. Okay, do you have this? Do you have this? Do you have this? Okay. You have a game plan just after like three or four questions of or an idea of where things are, and then you can move to what to do next. So you're meeting with a patient, you have 5 minutes in session, they say, I'm feeling suicidal, and you go, okay, you have these thoughts. Do you have you attempted in the past? No, I haven't. Do you want to do it? I mean, part of me does, but part of me doesn't. Do you have a plan? No. Okay, that's something, but versus yes, I have a plan. I have this in the back of my car. I have this and I want to do it. Okay, that's high risk, right? So this gives you a way to assess very quickly. Downside though, kind of going up here, it doesn't have scientific support. So this is pragmatic of how to keep a patient safe or like how to assess quickly, but all the research is done in these longer assessments. So what I would suggest as a therapist, if you're meeting with a patient, this comes up, you can then kind of refer out, like you determine it's high risk, you can call 911, 988. We'll go into those steps. Um, and you can allow other professionals to kind of make a more thorough assessment. So we don't want to just say, okay, let's talk about that next week. No, if a patient says, I want to die, or I'm thinking about suicide, you'll want to check. You'll want to make sure that it's not a high risk. Okay, so the Columbia Suicide Severity Rating Scale. This is what is used in a hospital setting like Aspen Grove. It's been in public domain since 2019. This is, actually, I'm going to skip that. This is what it looks like. So it's, like I said, this one is time consuming. This one is thorough. So I'll go over and kind of read some of this so you know. Um, I'm going to kind of backtrack for a moment, but this is what would be done in a sort of hospital setting. Now, what's interesting when I was putting this together, I came across this quote: "If you haven't asked about guns, you don't know how to do a suicide assessment." That really stuck out to me because when we go back up to those statistics, it's 50%, right? So that's something we need to ask about. So even though like in the crisis line, we didn't ask about that, in the the triage point. It doesn't ask about that. It's a good idea. It's a good idea if you have a patient who is impulsive and they're depressed and they have guns. This is a really good idea to know because that's a risk. That also goes into what to do next with like safety planning and the steps going forward. That means is important. So I encourage you as therapists, please ask your patients about that. All right. This is a triage version of the suicide rating scale. Um, so this is, again, this is not as scientific because it's short. It doesn't have a lot of research. It has some though, and it seems to be okay. But none of these short suicide assessments are going to be like really good. But let's go through the questions. Have you wished you were dead or wished you could go to sleep and not wake up? This is important to know. And if they say no, okay, well, yeah, they're probably doing okay. Have you actually had any thoughts about killing yourself? So it might be they want to be dead, but they may not have actually thought about doing it themselves. So when they say yes, okay, now we kind of want to slow down. So if you can see, this is kind of color coded. Okay, now that they've answered those two, let's slow down. Have you thought about how you might do it? And they say yes. Okay, now here this is now more serious. Um, so if we kind of color code green, go, yellow, slow down, red, stop. Have you had any intention of acting on these? Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry this out? Um, and you ask, have you done anything or started to do anything to prepare for this? Um, Typically, if you're in this red range and you have a yes in any of these questions that are red, that's gonna be high risk. Um, so this is a way to kind of color codes like low risk, medium risk, high risk. And so if there's a yes in the red, you know it's going to be high risk. Now the full suicide scale, it's much more in depth. Um, I might not go terribly into detail, but I do want to go over it because it's not something that I think a lot of people take the time to really go through. So, first question, wishes to be dead. The subject endorses thoughts about a wish to be dead or not alive anymore, or wish to fall asleep and not wake up. So you ask, have you wished you were dead or could go to sleep and not wake up? Fairly simple, yes or no. Second question, have you actually had any thoughts of killing yourself? Third, have you been thinking about how you might do this? Have you had these thoughts and some intention of acting on them? Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry this out? So this kind of gives you these questions to ask, and it also gives you a way to scale it and how to proceed. Um, it also has questions about the intensity of this ideation. How many times have you had these thoughts? When you have the thoughts, how long do they last? Could you stop thinking about killing yourself if you wanted to die, or of wanting to die if you wanted to? Was it? Could you stop thinking about killing yourself or wanting to die? This is kind of a worded question. Um, are there things, anyone or anything that has stopped you from wanting to die or acting on these thoughts of committing suicide? What sort of reasons do you have for thinking about wanting to die or killing yourself? So these are some of the questions that are there in this scale. And again, this is something that is used often in a hospital setting like Aspen Grove. And there's more parts of it as well. So this part asks about suicidal behavior. You go through, you check it off. Have you made a suicide attempt? Have you done anything to harm yourself? Have you done anything dangerous where you could have died? What did you do? Were you trying to end your life when you did this? So this kind of goes into more in depth as a way to kind of get a total number of past attempts. We also wanted to know if someone has had an interrupted attempt. Um, so this could be someone has was planning on doing it, but planning on overdosing, but someone came in and it stopped. Um, so this is part of what gauges this sort of severity. There's aborted attempts, there's preparatory acts. Um, so you want to ask, has there been a time when you started to do something or tried to end your life, but you stopped yourself before you actually did anything? Um, have you Now this one I think is interesting because that just kind of like step aside and talk about something else for a moment. This is gauging more like someone was thinking about doing it, but there might also be situations that don't fall in this realm. For example, if you've had a patient who was suicidal, they got to the point where they knew if they got out of bed, then they would go and overdose. And they say they lied in bed for hours. That's something that might not fit in something like this, might not be quantifiable in some way, but would definitely still be very significant. If someone has gone through that, that was something that they would likely be high risk. Um, Preparatory acts or behaviors. Oftentimes with suicide, sometimes it's impulsive and sometimes it's planned. So uh, an adult may think about, okay, does my life insurance cover this? What's my family going to do after this? So they might try to set up something for when they're gone. They might kind of go towards those steps for when they do leave, or they also might go through and start collecting a way to do it. Um, Pills, guns, um, things like that. All right. So this also kind of goes into some like lethality of the attempts. Um, so this is the type of assessment that has more research behind it that's done in a setting like this. But I think it's also very helpful for just everyday therapists to know this is like when someone is admitted into a hospital, it's not that admissions felt like, oh, you should come in. When someone has like an involuntary admittal or they're committed, um, there's a scientific basis for those decisions being made. And it's these, again, this has been studied. So this is one of the more accurate assessments out there. All right. So how do we score this? I'm actually going to skip this, but there is a way to score this. I'll kind of go over it quickly. If you want the slides, we can send this to you. You can go over it in more detail. Um, but for the sake of time, I'm just going to kind of go over it. So the name of the assessment. So this is Columbia Suicide Severity Rating Scale. But yeah, in the slides, there will be a way to score it. But for everyday, again, I think this is helpful for everyday therapists to go through. Um, but I mean, to just familiarize and educate yourself. But likely this wouldn't be used in a therapy setting. So this goes over more ways to score the subscale, and yeah, see triage guidelines for document for suggestions about what to do with the scores. So this is what I find interesting. We have the Columbia. We have a triage guideline for what to do with these scores. So there's the assessment, and then there's another thing that kind of explains what to do with the assessment. But ultimately, even then, it comes down to judgment. Um, so this is part of like that how to score it and what to do, what the recommendations are based on the score. Um, but even then, in some part of it, I think it's at the end. Basically, it says to make a judgment. So we have this document refers to another document, then it says based off of this we have recommendations, but use your judgment. So bottom line, that's what it comes down to. So in every situation where someone is being committed or asked to go to a psychiatric facility or to the ER first, it comes down to judgment. So in an everyday therapy situation, I think it's advantageous to become familiar with the kind of fast versions, um, and then refer out uh, to a CIT trained police officer or a mobile crisis response outreach team. Um, there's You kind of refer to another professional who will kind of do more in depth, and you go from there. Um, but mostly, you want to just make sure that your patient is safe. Okay, let's talk about medium risk. So let's say you're talking with your patient, they have thoughts about suicide, they have the means to do it. Okay, so now what? What do you do with that? Okay, so we don't if someone isn't immediate or high risk, they may not need to come to a psychiatric facility. But what is the next step? Now, some of you may be familiar with suicide contract, where a patient contracts not to follow through with suicide. Don't do that. Um, that's actually not helpful. The research doesn't support it. But safety planning instead, safety planning would be helpful. Um, so the first thing is you want to talk even before you get to that you want to talk to your patient. You want to talk them out of it. So let's say I'm talking with a patient and let's say for a moment they are high risk, but let's say they tell me right at the beginning of session, I have time to sit there. I don't have to make it, but I don't have to do anything right then and there. I can talk them out of it. We have time to de-escalate. Um, it's also important to remember crisis intervention differs from therapy. They are different. It's a different world. Things that I would do in a crisis intervention setting, I would not do in a normal therapy setting. In a normal therapy setting, I would never think to like guilt a patient. Um, if someone is high risk and they're saying, I'm gonna do this, I might use whatever tactic to get them to not for a moment or to think twice. So just asking questions, I might say something like, okay, so you want to do this. Who's going to find your body? Oh, what's that going to be like for your son to walk up and see you covered in blood? That's going to have an emotional impact. That's going to get them to kind of step back and be like, oh, there's a consequence to this. That's a different dynamic than like a normal therapy type of thing. That's in a way a harsh reality check. Um, but in these situations where a patient is at risk, the rules are different. Saying something like that, it's appropriate in this scenario. Um, so a reality check, you want your patient to know you have the same goal as far as them not being in pain anymore. Typically, people just want the pain to stop, right? We want that same thing, but any other way to get there. So getting them to feel like you have the same goal of them not being in pain, but also getting them on board with trying anything else. So instilling hope can be a very helpful. Um, but as far as like crisis, okay, my patient is thinking about this. I want to make sure that they're safe by the next time they come in. You want to safety plan. So safety planning, you can find templates on samhsa.gov. You can find templates on therapistaid.com, as well as many other different sites. So these safety plans, you want to identify warning signs. You want to know, you want your patient to know when not to trust themselves. So um, you want your patient to kind of sit back and say, "Oh, I'm doing this. I'm doing this. I'm probably in a bad place right now." You want them to have a list of coping skills. So this would be something that you give them. So you write this out. You write down with them what their warning signs are. You then have this section where you write down the coping skills that they are going to use when these warning signs start appearing. You want them to write down people or places that they can go to distract themselves. So being around people is important. It will keep them safe. Um, you want them to write down people that they can ask for help. So this may be a friend, this may be uh, a medical professional or a therapist. Many therapists aren't going to be available on call. So keep in mind, like, you want on this list to be people that can be available. Um, they'd want a list of professionals to contact during a crisis. So safety plans, and I'll go into some of this more in detail as far as like who to call. Um, but like 988, for example, or crisis line, and there's a lot of specific crisis lines that you could give your patient. Um, but once you have this for your patient, you have a printout, it's not a one and done thing. You want this taped on the mirror, something that they look at and it's just boom, right there. They can't get away from it. Somewhere it's visible and it doesn't fall into the background. And in the therapy process, you want to start referring to this. You want to talk about it. Do you have this at a place where you can see it? Have you been using these coping skills? Have you been identifying these warning signs? Have you read through your safety plan? You want this to become internalized. So we kind of first externalize it, just kind of give them a reminder, but ultimately you also want them to know it well enough that if it's not in visual range, they're still able to internalize it. Oh, I'm having these warning signs come up. Yeah, and revisit it. Come back or revisit it, but revise it, edit it as needed over time. Um, all right. Now let's talk about what to do if your patient is high risk. Um, Again, first thing is you want to de-escalate. That's where like that example that I gave that was somewhat shocking. That's what it is. You want to de-escalate to the point so that if they're high risk, that they can be cooperative to go and be assessed at another facility.
Who's gonna? There you.
Hello? I think someone was talking. Um, yeah, you just want them, you want them to be cooperative. Um, the experience of someone who is de-escalated to the point where they can be cooperative is going to be so much better than if they're not de-escalated. So this is an important piece. You don't want, as a therapist, we don't want to just say, oh no, you're high risk. I'm calling 911 right now. I don't know what else to do. You can still call 911, but there's this essential component of kind of bringing them down and getting them on board of what the next steps are. Um, because if they're on board and they're cooperative, it can be much more fluid, it can be much more streamlined, and it can be a much better experience for them. Whereas if they're not cooperative, it might be an awful experience for them. So this is key. You want to de-escalate. You want to kind of reality check who's going to find your body. What's it going to be like for them? Are your kids going to have years of therapy? What are your kids going to do without a dad? What are they going to do? How is that going to be? What's that going to feel like for them? You want them to see another perspective, take them out of their own, because in their own world, this is what they want. You want them to see another perspective, another viewpoint of what it might be like for someone else. Okay. So this is you'd want to call 911. This says fill out a mental health crisis packet. That's for Nevada, not here. Um, so let's talk about crisis skills. How comfortable are you talking to your patients about suicide? I want you to think about this. I know a lot of therapists, new therapists that tend to panic. Okay, someone's suicidal. I don't know what to do. I need to call 911. You don't need to right off the bat. You can assess, you can gauge that risk. If a patient has thoughts of suicide, but they're not planning anything, they haven't attempted before, these are just chronic thoughts, they're not on medication. Okay, you can sit there, you can talk with them. They want to process this. In therapy, they're bringing this up because they're hurting. A lot of times people are afraid to bring it up because they don't want an overreaction. So this is why determining risk is so important, because if risk is low, you can work through that in therapy. You can game plan, you can look at different medications, you can refer to doctors for that, but it can be a healing process. What we don't want is a knee-jerk reaction of, uh-oh, you're suicidal. You said the buzzword, I have to call 911. That would only reinforce to someone who is not at that stage, um, that if they bring it up, it's going to have a big consequence. And so they may learn, I don't bring it up. I keep it to myself. We definitely don't want that. Um, now, when and I talked about this a little bit already. Why is it important of talking someone out of suicide before calling 911? The experience will be different. So I'll walk you through what it looks like in another state. Um, let's take Nevada. In Nevada, a therapist, any therapist, um, can fill out some paperwork. So when they call 911, they can say, hey, I filled out a legal 2000. Can you send an EMT? So the police don't show up, an EMT shows up, you give them the paperwork, they would transport the patient in an ambulance to the ER in that state. They would be medically cleared and then moved from there um, to an inpatient facility. That experience is a lot better than a police officer showing up. Um, and that experience is even then when that person doesn't have an emergency contact. So there's the emergency contact And there's like how to make this less stressful for the patient, and then 911. So here in Utah, police officers, whether you call 988 or 911, police officers are going to be on site. And often, I believe it will be trained police officers, a CIT, crisis intervention. Uh, so they will be trained in how to handle these scenarios. But if you call MCOT, Mobile Crisis Response Team, say there's several different numbers for that. Let's say you call 988, they send out a team. The police officer is just there as a precaution, hanging out, making sure everyone's safe and okay. Um, and the experience for the patient might be that the officers in the background, they're able to talk with a therapist. They might be able to get into an ambulance, and that's the type of experience that they would get. Now, if you call 911, it may be that they're put in handcuffs and they're brought in a police car. Um, that's that might not be great if you feel like, hey, I was vulnerable. I opened up about my feelings, and now I'm being put in handcuffs. That kind of sucks. So it's important to know like why it's important, like why you need to try to de-escalate and get a patient to be cooperative. If you can't get a patient to be cooperative, yeah, you just go right to 911. Um, all right. Talking a patient out of suicide. Um, this is a quote. I did not include where I got this from. The findings also suggest that people do not need a script and should not be afraid of saying the wrong thing. What interveners said was much less important than how they made the suicidal person feel, namely safe, connected, validated. So, you're a new therapist. Your patient says, I'm suicidal, and you're afraid you might say or do the wrong thing. But if you just let them feel heard, you can de escalate just from reflective listening. Oh, that sucks. You're in that much pain that you just want to end it. That must be an enormous amount of pain. I can only imagine how heavy that must be. That's that's going to help someone feel heard. That's going to help them feel seen. Um, So it's important when you try to talk to someone out of suicide, you don't panic. Don't panic. And if anything, like just from like a mirror neuron perspective, by you not panicking, it's going to help them feel safe. If you panic, they won't feel safe. So you have to regulate yourself and be present with your patient. Uh, it's not so much what you say, it's how you say it. It's kind of with language in general. You want to make the patient feel safe, listen, validate, instill hope, make sure there's light at the end of the tunnel. That's an important piece. All right, so let's talk about what this process looks like. First thing, after you, let's say, call 911, um, they are going to be taken into custody. Law enforcement, medical professionals, they're going to be transported. Uh, Oftentimes it's to a hospital or an ER, but it can be directly to a behavioral hospital. Um, but if there's anything medical going on, likely they'll go to the ER first. In those cases, they're usually examined for any sort of medical problems and then referred to a behavioral problems or behavioral hospital. They'll be evaluated and assessed there. Okay, yep. And then the doctor will say you need to go to a behavioral hospital. Sometimes I think it's referred to as a blue sheet. And then they will go to the hospital, the behavioral hospital. That is when their hold starts. Um, as soon as they're admitted uh, into the behavioral hospital. Um, so who does what? It's different in each state. Here in Nevada, not every therapist has the ability to mandate or commit a patient. Doctors can do what's referred to as a blue sheet. Um, did I say Nevada? In Utah, you would have to be trained by your local mental health authority. So you'd have to get training and a certification in order to be able to do that. So as a therapist, when a patient comes in, we're going to refer out, we're going to do kind of a quick assessment, and then we're going to refer out so someone can do a more thorough. Um, Police officers, see, crisis intervention trained officer, they're going to have that ability. So our options are 911, 988, if we're getting them to be involuntarily committed. But that's also not our only option if you de-escalate. So there's these terms that I was somewhat unfamiliar with. There's pink sheet, blue sheet, white sheet. Basically, pink sheet, that's written by a therapist who has this certification or this authority. Not every therapist can use this. An ambulance, when called, they can't do a pink sheet, but like a police officer can. Blue sheet, it's similar, but it is from a doctor, allows someone to be held for 24 hours. So there's three main things to do when someone is actively suicidal and high risk. So there's 911, there's 988, or there's emergency contact. If you are able to de-escalate a patient, and if you're able to get an emergency contact, you can make this process so much more streamlined, so much more or less bothersome. Let's say if I had a patient, they're suicidal, we call up, we let their spouse know, hey, this patient, they're suicidal, they need to go to a hospital. Are you able to drive them to a behavioral hospital right now? And they say, you know what? I'm dropping what I'm doing. I'm coming. I'm going to drive them. So then they're on their way. I'm with my patient. We call up a behavioral hospital. Hey, I have so and so with me. They are suicidal. They're not safe. They're not, we don't trust them to be by themselves. An emergency contact is coming and they will be there soon. So now you've let the hospital know and their emergency contact know. You facilitate, well, someone else, that emergency contact is going to be transporting them. That is skipping a whole lot of steps. There's no emergency room. There's no handcuffs. And it can be a much more streamlined and pleasant experience. That is, in my view, the best way to go about it. Uh, Emergency contacts can and should be likely contacted when a patient is actively suicidal. And we think, well, wait a minute, we're contacting them and we're sharing valuable information about our patient. Is that a breach of confidentiality? No, no. Confidentiality goes out the window when someone is in an immediate crisis. So no, you have permission in this sense to contact the emergency contact. So this is the ideal thing. When your patient is suicidal, we want to contact the emergency contact person. We want to get them to take them and drop them off. But this is all under the assumption that they have been talked out of it. If you can talk your patient out of it, and if they can give you this verbal response, if you trust that they're going to be okay, then the emergency contact going straight from there to the hospital, great. But that's the key component, is they have to be de-escalated to that point. So there's pros and there's cons. You can bypass police, bypass the ER, bypass being put in shackles. It's going to be a lot faster. It's going to streamline the admission process, and it may be a lot less traumatic. Going to behavioral hospital is not a fun thing. It sucks. We want to make it as pleasant as possible, as comfortable as possible, and this is one of the ways to do that. The cons, the patient has to be cooperative. The contact has to be cooperative. And they have to have the willingness to take the patient to the ER or to the psychiatric hospital. So there's a sort of decision tree that I have for you of recommendations. I'm going to go over that. So if your patient is cooperative, the recommendation is contact emergency contact, explain the situation, get an agreement for the patient to be transported to a behavioral hospital. Then you'll want to contact the hospital, explain the situation, let them know that the patient is on the way. Let's say, though, the patient is cooperative, but something's off. Your patient is cooperative, but there's a strange look in their eye. They're talking about things. Um, they maybe, I don't know. You suspect there might be a medical problem. Okay. Now you can still do emergency contact, but at that point, you might want them to go to a hospital, an ER, to see if there's anything medical going on. Um, and you can call 911, explain the situation, have the patient be taken to the ER. There's going to be times where it is a medical thing. So if you know that it's likely not, this is just depression, yeah, kind of going up, best experience for the patient would be being transported by the emergency contact. Otherwise, if there's something medical, you want them to go to the ER and evaluated there just to be safe. If the patient is cooperative, not displaying medical problems, and the emergency contact is not available. Okay, so you can't get a hold of family members. You still don't want your patient to have a bad experience. How can you make it not as bad? 988. So instead of calling 911, you call 988. So 988 is going to be able to get in touch with the MCOT, Mobile Crisis Response Team, or Mobile Crisis Outreach Team, in whatever part of the state you're in. They will be contacted and they will be sent to your patient. Potentially. Now, if it's a very rural area and the mobile crisis outreach team is very far away and it's going to take 3 hours, okay, that brings up something else. But if it isn't in a rural area, you can't get a hold of emergency contact, you want to go this route of calling 988, having a therapist come, the the officer will be hanging out in the background. The process will be a better experience for your patient. If it is in a rural area, it might be very time consuming. So at that point, you might call 911 just so that they have transport when it's fast. If the patient has emergency contact with that or a person with them and they're safe and they can wait 3 hours, okay, that's one thing. But likely in this scenario, you haven't contacted the emergency contact. So in a very rural area, it might be best for your patient's safety to call 911 and have a police officer come. The officer likely will be trained. You can ask for a CIT trained officer as well. So someone that has that training is going to go about things a little bit differently. They're not going to go about it in a very provocative way. They're going to go about it in an empathetic way. They're going to know what to expect and how to specifically help. So that's something to keep in mind. So with calling 911, you can call with your patient. I've heard you can even text 911. I'm not so sure if that's true. But you can call with your patient or you can excuse yourself. So if your patient is cooperative, I would say there's a benefit to doing it right then and there. If you are afraid that your patient is a flight risk, excuse yourself, go or have someone else call for you, make that phone call and be present with your patient until the police arrive. So the cons of 911. It sucks having, police show up, being put in the back of a car. Sometimes you aren't. Sometimes you aren't put in an ambulance. If it's a rural area, it might be the back of a car. It might be handcuffs and shackles. Um, we don't want this to be any more uncomfortable than it already is. But there's times where this is what we need to do. We need to call 911 because we need to make sure that our patient can be de-escalated because they're not in a cooperative place. Um, and we need to make sure that they get to the police will make sure that they get to the hospital in the ER setting. So when emotions take over, that's going to happen. You're going to have moments like that where someone can't be de-escalated, and so that's what you do in those situations. But that's how they will be safe. The
Hey,
pros,
Preston,
yeah.
there's a couple questions regarding the legalities of making sure they get to the emergency room if they're sent with their emergency contact. Like what does that entail?
Um, if your gut's like if you're concerned about that, like I'm not sure about the legality, but if you're concerned that they're not going to make it, don't have the emergency contact. This would be only in situations where your patient is super compliant and cooperative and you trust it. Um, if you're concerned even then about the legality, call 988. If you feel like it's a risk, call 988. It's better to call 988 and not have an emergency contact transfer them. Instead, you call 988, you have the mobile crisis outreach team come and you call the emergency contact to inform them, hey, I was just with so and so. They're they're being taken to the hospital. So if this I wouldn't want anyone to feel like they need to put their patient at risk. So if your patient is like not 100% on board, like I understand I need to go to the hospital and I'm willing to go, um, you just don't want your patient to take themselves. You want someone to be with them, right? Um, so ideally, it's not going to be very often where I think a therapist really trusts that, but there are times where a therapist, and I've heard of where that is the case, and an emergency contact does transfer them, and it's a streamless process. So this is a way to kind of make it more of a streamlined process. Um, but as far as patient safety, if there's any part of you that thinks that they may not make it, call 988 and just inform the emergency contact. Does that answer the question?
I believe so. That was awesome. Thanks.
Okay. Um, all right. So the pros of 911 is they're the fastest responder. So a rural area, it's very helpful. Um, they'll be picked up, taken to a room, but an alternative is mobile crisis outreach team. Therapists will be sent to do the assessment. Police officers will be present, take a less active role. Transportation may be an ambulance. But since an ambulance cannot pink sheet, we have to call MCOT. Um, Instead of memorizing all the different numbers for MCOT, just call 988 and they will send out, or they will get in touch with MCOT or the mobile crisis outreach team. Um, so they are throughout the state in each area. Yeah, just rule of thumb, call 988. If you have their number, you can call them directly. Otherwise, you can just call 988. Um, so 988 versus 911. Basically, if your patient is cooperative or not. If my patient is cooperative, cool. 988 might make this experience a little better. If they're not cooperative, nope, call 911. So it yeah. I mean, maybe you could, and I guess the reason for this is that response time. Is you'd want someone there, you'd want to make sure your patient is safe, and if you call 988 and they're not going to be there for 2 hours, uh, that's a liability, and that's a risk. So 911 is recommended if your patient if your patient is not cooperative. We talked about this earlier. If you're in a rural area, yeah, call 911. It's going to be easier. So, all of this, and I'm talking about this sort of decision tree of what to do when, just so that we can make this process a little bit less bothersome for the patient, a little bit less traumatic, a little bit less uncomfortable. But the first thing first, you want to de-escalate your patient, get them on board. You want to call the emergency contacts. You can call the hospital directly. And remember, confidentiality goes out the window. You can call these emergency contacts. That's okay. You can talk about it. So if this is the first time the situation comes up and it's the first time you have to do this, you're okay to call the emergency contact. You're okay to call 911. You're okay to call 988. This might not be the norm, but this is the exception, and it's okay for you to do that in this scenario. Okay. MCOT or 988, or how's 988 different? I think we've gone over that. We can kind of skip ahead.
Hey, Preston, there are just a couple of questions in the chat. For example, Tyler's asking, would it be appropriate for a therapist to call 988 just to familiarize themselves with that line and better understand the process that follows to better help clients know what to expect for such an event that occurs? Or is that
That's
kind of like 911 where maybe we're tying up resources if we're spending unnecessary time on a line?
yeah, that would be my concern, is that it would be tying up resources. So I wouldn't recommend calling. I would maybe just I would look up some other numbers to call, some other non-emergency numbers, look up MCOT, look up that number. You could potentially call that number and ask the same questions as if you called 988, and it would likely, because I think they do have a non-emergency number. So that's, if you were to go about that, I think that would be the better choice. Oh,
Great.
okay.
There was one other question. If it's a telemed appointment, what do you recommend?
I mean, kind of the same thing. I would just act more on it. If it's telehealth, I would consider the risk to be greater. I would likely act sooner and try to get someone present, and preferably present before, before the end of that session. So, you wouldn't want them to leave that area. So I'd make sure like you get the information of where they are. You would call 911, and get someone there sooner than later. So I would err on the side of caution if this is. Now, if it's my therapy office, I know that, and I have them for an hour, I know they're safe for an hour, I would take the time to kind of de-escalate. If you're seeing that they're escalated, you feel like they're at risk, I think you can be more proactive. I would personally, that would be my choice, is I would contact 911 sooner than later, um, just so that they're going to be safe. All right. So the warm line different than the 988. Who answers the call? It's a good question. I think that would probably be a better, as far as a line to call to ask questions, that would be better to call that instead. Also, they may have those same answers and may have some of that training. And that is different. The warm line is more for a patient is emotional. They may not be suicidal, but they're emotional and they need someone to talk to. The warm line is a good resource. The 988 is more suicide and crisis intervention purposes. Okay, so if you observe a patient that has medical problems, again, call 911, have them go to the ER. Now this next part, we're going to talk about the documentation. Um, I heard someone say, I don't know if I agree with this, but I was reading about documentation and there was this quote, "It is more important to provide justification of suicide risk than is well reasoned than one that is right." Um, I mean, I would say that it's important to have well-reasoned documentation, but I wouldn't make that argument that it's better. But something that you can familiarize yourself with is CAPES, CAIPS. It kind of goes over an outline of how to document this type of thing. So it goes over chronic and acute factors, protective factors, imminent warning signs, a summary statement. And this is all for maybe a selfish purpose of covering the therapist and making sure that if the patient is upset, that there's good evidence and reasons why you made the decision you made. But ultimately, those decisions are going to be a judgment call, and you're just going to want to write down why you made the decision you made. So in this recommendation, you'd want to address the chronic acute factors that weigh heaviest, past events, yeah. I would encourage you just to Google CAPES. It's going to kind of go over it in detail. So here's a way to kind of a way to remember the warning signs. If there's ideation, substance use, purposelessness, anxiety, if they feel trapped, hopeless, withdrawal, anger, reckless, mood, these are things that you would document. Other things to consider: if they have access to means, the lethality of means. Let's say I have a patient and they say they know how they want to die. They want to jump off. They want to jump off a bridge or jump off a building. And they live the furthest the closest building to them is an hour and a half to 2 hours away in a vehicle, and they do not have a vehicle. That sort of means is not actually there. So they don't have that ability to follow through on how they want to attempt. So these are things that can be considered. Now, if they live in an apartment building 20 stories up, okay, they're constantly in that environment. So that's going to kind of shift how I see that situation. So with the documentation, also you want to discuss protective factors and just as far as treatment, some things that going forward you want to emphasize these things, but if you're documenting, saying, hey, there was a lack of these things, and then you want to make a summary statement. Again, if you Google CAPES, CAIPS, you'll be able to kind of get that in detail. I didn't want to spend too much time on it because it feels weird. It kind of feels weird to me. It's something to address. But like ultimately, if I make a recommendation for a patient, it's because I'm concerned and I want to make sure they don't get hurt. I don't care so much as my documentation. I know it's something to consider, but like I just want to make sure my patient's okay. But for best practices, it's something that may be wise to familiarize yourself with, or to look at after a situation has occurred, to know about how to document everything. So this is a sample justification of suicide risk using this CAPES method. Looking at the time, I think I can read it. Chronic risk is at least moderate for the patient, Mr. W. Because of his 2 previous suicide attempts, risk is amplified by acute psychotic symptoms, paranoia, derogatory auditory hallucinations, and several warning signs, most concerning of which are the intensity of his desire to die and his belief that his psychiatric condition is hopeless. Mr. W considers his symptoms as intolerable and interminable and inescapable, all of which can be used to rationalize suicide. In addition, he has demonstrated the capability to harm himself. Previous attempts to overdose with olanzapine and his intermittent use of methamphetamine could lead to impulsive attempts. Although Mr. W has some protective factors, I'm Christian and killing yourself is an unforgivable sin. Family members want to see me out of prison. They appear to be overwhelmed by his current distress. Because of this picture, the patient is at severe risk of attempting suicide if his distress does not abate in the near future. So seeing this is a well-reasoned, justified reason for a recommendation for calling 988, for calling 911. So for documentation purposes, this would be something to familiarize yourself with. Let's see. All right, let's talk about what works and what doesn't. I talked about suicide plans. Just a reminder, suicide or do the safety plans. Don't do the suicide contracts. I think you kind of put those two together. Suicide contracts don't have like good research behind it. If you say, hey, I'm going to have you commit to not self-harming, I'm going to have you write in this contract that you're not going to attempt, it's not going to help. Instead, have a safety plan, have them familiarize themselves with it, have them externalize it and then internalize it, have it be something that you revisit, you talk about. But all of this is under the assumption that you're continuing therapy. And you may, but also they may need something more. If your patient is suicidal, there are these different levels of care that may need to be addressed. Again, this is going over the safety plan, coping strategies. This is in the slides. You will get a copy of it. Making the environment safe. You'll want to have, if I have a patient who's suicidal and they just got back from the hospital and they're coming to see me, I'm going to make sure they don't have access to guns or knives or ropes. I'm going to have them have someone hold it or have their spouse lock it up, remove it, make sure there aren't sharps, because it's wise to distrust themselves and it's wise for us to distrust them, because an emotion can take over and we want things out of reach. If an emotion takes over and there's a gun within reach, that's a problem. We don't want that. If an emotion takes over for 15 minutes and that gun is secured in a safe and they don't have the key, they're going to be okay. So this is a key part of safety planning, is making the environment safe. It's okay for the patient not to trust themselves. It's smart. Their life may depend on that distrust. I don't trust an 8-year-old to drive me in a car. That does not mean I have anything against 8-year-olds. I just think it's smart if they don't, because they don't have that experience. Like, distrust is an okay thing. It doesn't mean anything more than that. It doesn't mean your patient has to shame themselves or feel like they're a bad person. There's just a part of them that takes over, and we want to prepare for that. I see hands coming up. I'm going to get to questions a little bit later. So I have a few things I want to go through. In fact, I might, I'll try to get through these quick. I will include them. So for long-term treatment, the psychotherapy must be designed to treat the depression. You need means restriction, you need a safety plan, and it needs to be structured. So there's different types of therapy that are helpful for depression, but you want that to be the target. So there's attachment-based family therapy. This is interesting because a lot of you may have thought I would start out with something like cognitive behavioral therapy. This is a program with evidence. It's evidence of effectiveness. It's considered, this program, I believe, is considered evidence-based. But it's a 16-week program for 12 to 24-year-olds. It helps with secure attachment, emotion regulation. It kind of works from multiple angles. So what I find interesting is this is coming from this systemic lens. Instead of just changing our thoughts and working on our behaviors, this is coming from the lens of things don't hurt as much if I have people there for me. So that I wanted to include. Behavioral therapies, more common for evidence-based therapies for depression and suicidality, cognitive behavioral therapy, mindfulness-based cognitive therapy, dialectical behavioral therapy. All of these are going to be very good at helping your patient have skills and knowing what to do when an emotion comes up, how to cope, how to respond, how to change their thinking, how to get out of that schema of seeing the world as a certain way. Now, if there's PTSD also involved, you could do something like EMDR, which is working from an entirely different perspective. I would not suggest it as a standalone, but as more of an addition to. But that could reduce emotional reactivity. But I would encourage them to also be doing like a behavioral therapy as well. Now, what's interesting about all of these, so attachment focus, EMDR, cognitive behavioral therapy, you have 3 therapies here that are working from entirely different mechanisms of change. You have extinction through cognitive behavioral therapy. There's you have memory reconsolidation working with EMDR. You have secure attachment as a mechanism of change with attachment-based family therapy. So you have unlearning an emotional reaction or trauma response with EMDR. You have learning a new response through cognitive behavioral therapy. And then things just aren't as hard when you feel connected with family. So I wanted to include all of these sort of perspectives to show you that if you are skilled in one of these modalities or skilled in these areas, you can still be helpful for your patient. But the gold standard is these behavioral therapies. This has the most research. This is going to help them the most. I'm not saying it's the only type of therapy that can be done, but this is important. So I encourage you not to neglect those. With psychiatric care, you want to get a psychiatrist on board. You want their psychiatrist or prescribing physician, you want them to be on some sort of medication. Now, there's some reactions some people have to SSRIs with certain ages. This would be more in the realm of like a doctor or a psychiatrist. Some of the things I'm including on here, like this is saying lithium, that's also like 20 years out of date. It's still in like a lot of the textbooks, but like if there's a psychiatrist or doctor that goes another route, likely they're up with all the more recent research, and don't worry, they probably know what they're doing. But for whatever reason, in a lot of the publications, there seems to be this gap of like, here's what's cutting edge and here's what's evidence-based. By the time it gets to evidence-based, we're not in touch with what's cutting edge. Anyhow, that's a whole other soapbox. Protective factors to decrease risk. I'm going to kind of skip through these quickly. You want them to have reasons to live. You want them to have a sense of responsibility. You want them to have positive coping skills. All of these things can be helpful. this is what I want to slow down and pay attention to. So levels of care. So you have a patient who's suicidal. They might need more than once a week therapy. They might need more than once or twice a week therapy. There's different levels of care that are recommended for different scenarios. When a patient goes into a hospital setting, like Aspen Grove, they leave and are usually sent to an outpatient, or typically it's intensive outpatient, day treatment, or residential. Those are kind of the big three. There's some exceptions of things like a therapeutic boarding school. There's the state hospital when someone is very severe and they're not safe to be in a residential. And then there's outpatient where this person has never had therapy before, but now they're on medication. They may be okay with just once or twice a week therapy. But I want to talk about these different levels of care, what they are, and when it's appropriate. So outpatient, we know that's 1 hour a week. Intensive outpatient, this is 3 hours or 3 times a week for a couple hours. It can involve group therapy. Group therapy is evidence-based for suicidality. It can involve med management, but doesn't always. So usually these have like a behavioral therapy like CBT or DBT with that sort of modality. There's partial hospitalization. This is more intensive. This is not just 3 times a week for a couple hours. This kind of takes a place of school. It's like school. It's from 8:30 to 3, for example, might be different hours. But for teenagers, it could take the place of school. These programs will coordinate with schools, provide credit, so that the patient doesn't have negative consequences for not being in school. Usually this involves med management, meaning there's a doctor on site seeing patients. Then there's residential. This says 1 to 3, but it's really 1 to 4. This would be a patient is not safe to go home. They're at risk. They need deeper work or need some sort of more stabilization. Multiple modalities are often used. So they may have emotionally focused family therapy, dialectical behavioral therapy, EMDR, equine therapy. Not all of these programs have these, but these are just examples of multiple modalities that could be used in a setting. All right. So this is something that will be important, hopefully. Oh no, it won't let me. So when I was preparing this, I could scroll up and down. I might see if I can change this for a moment. I'm going to go through this. So this is the difference between like inpatient, residential, day treatment, and intensive outpatient, and what type of patient needs to be there. So start with suicidal thoughts. If someone has made a recent attempt or immediate risk of acting on those thoughts, an inpatient facility like Aspen Grove is what is recommended. If they're stable and they have chronic, severe suicidal thoughts, multiple attempts in the past, there's treatment-resistant depression. Okay, yeah, that residential would be appropriate. Maybe it's not quite that. If there's current suicidal ideation, there's a near attempt, they're trying to go by and do the safety plan, but like they're having these moments of relapse. Okay, day treatment is appropriate. If it's the suicidal thoughts are mild, occasional relapse, but they're honest about it, they're taking accountability, they're able to kind of just work through things, yeah, then intensive outpatient. If there's self-harm in an inpatient facility, it may be that someone has multiple injuries, where if it's like they have occasional thoughts of self-harming, they might have a couple relapses, they might self-harm a little bit. Okay, maybe that's more appropriate for intensive outpatient. So I have here kind of like a sort of grid to show you with each behavior what is usually recommended for each scenario. So if someone has chronic, severe suicidal thoughts, probably intensive outpatient is not enough. If they have multiple attempts, probably residential is going to be more appropriate. Now, this can vary from person to person, but these are general recommendations. If someone's having homicidal thoughts, yeah, typically we'd want residential for that. If someone does not have any sort of aggressive behaviors, they're able to redirect themselves. Okay, yeah, maybe intensive outpatient. But on the flip side, let's say someone's getting into fights, starting fights. It may be that an inpatient facility to get them stabilized, like Aspen Grove, would be appropriate. So this is good, I think, for the average therapist to know. If you have a patient and it looks like they're in this residential column and you're just doing 1 hour of therapy a week, I strongly recommend that you have a conversation with your patient and talk to them about these levels of care and see if you can get them in touch with an assessment, see if you can bump it up. I think sometimes as therapists, we may not be aware of all the extra resources that are available. Now, it may be that I'm preaching to the choir with some social workers, but there might also be some marriage family therapists that this was glossed over in a paragraph in school and never really talked about again. In which case this would be a good refresher, and you could look at this and say, oh, okay, there are these things that are available to my patient. Looking at this, it looks like my patient is falling into this column. I can talk to my patient about this and say, look, based on like what we're looking at here, residential would be a really good thing for you. We're just doing once a week therapy. Like, we got to bump this up, and you might get them to settle on something like day treatment or intensive outpatient, or maybe they'll be like, you know what? If I could get that help, I'd take it because I don't want to live like this. So, uh, this is something that I want you to be aware of. What I'm going to do though is I'm going to see if I can go to that slide and scroll down so you can see the rest of it. Um, okay. So there's these risky behaviors. If someone's running away, like a kid's running away a lot, okay, we wouldn't want them in likely an inpatient facility or an RTC where there's some sort of barrier. Not all RTCs can facilitate helping someone that's a flight risk, but some can. If someone has risky behaviors of like they're in exploitive relationships, they're allowing themselves to be exploited, or there's some mild disordered eating, maybe once a week therapy isn't appropriate, but in this scenario, it would be recommended something like partial hospitalization at least. If there's medication concerns, if someone is continuing to take medication, showing signs of progress, great. If you have a patient that is not stable, they don't have medication management, and they need someone, yeah, then this is something to take into consideration when you're looking at these different levels of care. This is something that's important to me, so I'm going to pause it for a moment and ask if there's any questions about these levels of care. Jump to the latest. Okay. Yeah, like Joseph said, this will be in the slides. You can review it. Residential care. So this is a good question, because where do you find like residential care? There, this is actually like even like at the behavioral hospital, like where I work, we have positions where this is what someone does. They are strictly in charge of taking a patient and sending clinical paperwork out to residential facilities and coordinating that kind of handoff. So it can take a bit of skill to find. It can take some time. It can take some time to find a place that takes the person's insurance. But really, you could use their insurance provider. You could get in touch with them. They could contact the insurance provider. They could get a list. You could use something like Psychology Today as a resource. It may not differentiate whether it's substance abuse or teen or adults or the type of residential facility. But there's several. There's several throughout the state. The trick would be to find one that actually takes your patient's insurance. So it can be a process. So what it looks like to get into a residential facility, let's say if we have a patient that's going to a residential facility, we send that facility the clinical paperwork of our patient. The facility will review it, and then they'll call up the patient. They'll have an assessment done. Then there'll be an internal acceptance, and then they will send an authorization request to the insurance company. And then a few days later, the insurance company will approve it. So it can be in a setting where someone's in a hospital, it can be a little bit of the process. For someone that's not in a hospital, a week wait extra isn't huge. So, but in order to find one, your best bet might be to call. I suppose you could call your insurance, or you could Google. But no, it may take some digging. And then there's some places that they're not paneled with insurance providers, but they operate on single case agreements, in which case your insurance won't let you know about them, but it might still be an option. If you were to find a place, it looks really good. It would just be kind of a gamble whether or not the patient is accepted. All right. I should probably hurry up, but yeah, this will be something that you can come to and kind of go through. I think that's fairly important. We went over protective factors. Let's see. Risk factors. This next portion, I just wanted to show how each specific diagnosis has specific risk factors that come along with it. This will be in the slides that you will get. Because of the sake for the sake of time, I might go through this part a little bit quickly. But with anxiety disorders, you're going to have a higher rate of suicide risk. 30% of first suicide attempts can be attributed to a specific phobia in ages 14 to 24. That's a lot higher than I think a lot of us would expect. There's increased risk with social anxiety disorders. In some communities, like the Latino community, but maybe not necessarily other communities like Caucasian. So there's certain demographics that might be more at risk with certain disorders. The middle-aged white male has the highest rate of suicide. Panic disorder, we're going to see 25% primary care patients with panic disorder reports suicidal thoughts. So there's a lot of this comorbidity. So something to be aware of. And in what I like about the most recent change with the DSM is if you go to the end of like the discussion of that paragraph or just that part. So you're looking at panic disorder, you go through the criteria, there's the discussion area in the DSM. It's going to have a part of that that talks about risk factors for suicide on each disorder, which is kind of cool. So 15% of individuals with agoraphobia report suicidal thoughts or behaviors, generalized anxiety disorder, obsessive compulsive disorder, PTSD. It's increased risk for both civilians and veterans. ADHD. We have like an impulse, impulse issue here, and impulsivity is one of the things that makes suicidality or thoughts lethal. Females with untreated ADHD are 5 times more likely to die by suicide. That is a huge statistic. So when you get this, you can kind of go through it, but because of time, I'm not going to go too much into each of these. There's some genetic components, there's systemic components. I have some quotes from a local professor here, Dr. Quinton Hunt. There's interesting aspects of neuroimaging, of suicidality, some fMRI research that's in here that talks about like impairments in the ventral prefrontal cortex, the dorsal prefrontal cortex, and the insula. We even with EEG, there's alpha asymmetry where it's more dominant on the left. If there's alpha asymmetry, it's more dominant on the right. That's associated with anxiety. So there's interesting research that's being done. When it comes to suicide, it's important that we distinguish what's okay to talk about, like the myths from the facts. When you ask a patient about suicide, you're not putting the idea in their head. It's not going to increase their risk. It's okay to be that direct. There's a myth that people who talk about it don't want to do it. No, most people who complete suicide communicated some sort of intent. So if a patient is talking about it, this isn't just they're getting it off their chest and they feel better. This is something to keep in mind. There's a myth that if someone really wants to do it, there's nothing that we can do about it. No, there's a lot that we can do about it. It's very easily treatable. There's a myth that you can rely on a contract for safety. No, you can't. The contract is useless. The safety plan is better. All right, I got through most of this. There's other populations at risk. Native American men. Alaska Natives have second highest suicide rate in the nation. LGBTQ. People who are trans, very, very high risk or high rates of suicide. 52% of trans and non-binary youth have sincerely considered killing themselves in 2020. So these are things to consider. And thank you for your time. And I see someone wanted access to my email. My email is preston.walker@uhsinc.com. If you have any follow-up questions, you can email me. And just another quick plug for the training this Saturday. The previous evaluations that I have received for my past trainings on parts and memory therapy was 97% positive. So when you like go through and you rate everything, I totaled it up, it was 97%. I think that means it's a good training. I think you should come. I think you'll learn a lot. And Joseph, thanks for allowing me to make that plug.
You bet. You bet. This has been great. And, I think I echo everyone, today when I've seen a few comments come in. This is an awesome presentation. It's chock full of, a wealth of resources. And I think for a lot of us, it's very informative. There are questions sometimes that come up and just dealing with these things on a daily basis that sometimes we just stop and think, yeah, I maybe breezed over this in training, or I spent just a limited amount of time on this. And so it was good to kind of refresh us in terms of like what to do in these circumstances or how these certain, situations are classified. So that was very helpful. Thank you, Preston.
Yeah, you're welcome.
So there's a question by Mark here. Why do people in Utah commit suicide at a higher rate?
I was just replying. I read one article that was looking at that, and the proposal in this article was looking at different places across the U.S., places with higher suicide rates, and there was some commonalities. One of which was air quality, altitude, and pollution, which I thought was fascinating because I never would have thought of that. I would have thought there's some sort of, difference with the people. But I think there's likely many factors, and it would be difficult when studying something like that. You'd have to kind of look at the whole of all of these things put together. So it might be that something like altitude does have some difference, but might not account for why it's much like as higher as high as it is. So that's a good question. I don't know. I don't know what those other factors would be. All right. Well, thank you so much. I'm going to be logging off. Thanks again.
Thanks, Preston.
Yeah, thank you.